thanks for the team at OneWelbeck for organising this. There's some familiar faces and some that I haven't seen before, but I'm Asif Munir. I'm a consultant urological surgeon at University College London Hospital and also at OneWelbeck. And as you can see, today's theme was all to do with cricket, I was told. So, I've come along dressed appropriately, but I didn't realise our special guest today was going to be David Gower. For those of you who know anything about this great game, David was an ex-England left-handed batsman throughout the 80s and 90s, one of the highest run scorers for England. Also played for Leicestershire. I used to watch him when I grew up, going to Grace Road, and I modelled my cover drive on his. Although I'm right-handed, he's left-handed, but mine looks a little bit better. So, but anyway, so it's an absolute pleasure to have David here. And for those of you who don't watch cricket, you might have seen him on television doing Sky Sports. And what was that quiz show that you used to do as well? Was it? Do you think it's all over? Did you do that?
Yes, I have to own up to that.
Yeah, that's it.
Which was largely question of sport with jokes.
Yeah.
With better jokes.
There's better jokes in question of sport.
Not necessarily mine, to be fair. Question of sport gone very wrong. But very, very competitive. Another famous sportsman, Mr. Lineker, Gary.
Yeah, that's right. So two Leicester boys, just like me. So, I only grew up 10 years in Leicester. I moved south, like proper.
No, we all do that.
So I got out when I was young. But anyway, So thanks for coming along, David. We've also got a panel. So it's a men's health theme today. So I just want to introduce our panel. So my first panel member is Mr. Anthony Noah, who's also my colleague at University College Hospital. So Anthony is a urological surgeon who specialises in complex reconstructive adolescent congenital urology. So anything that's rare. He also does female incontinence, female bladder pain, etc. So he's an expert in that. So I'm delighted to have Anthony here to join us. Because he also deals with all sorts of bladder problems. So we'll be putting that into our case study that we're going to discuss today. So Mr. Ahmed Ali, who's at Frimley and also works at OneWelbeck. So he's, again, a urological surgeon dealing with prostate, bladder cancer, testes cancer, BPH, so any benign prostatic enlargement, bladder outflow obstruction, stones. So he's a jack of all trades. And I'm delighted he's joined us as well. Then we've got Bal Wasson, who's our cardiology expert. So Bal's at St Thomas's, and he specialises in any cardiovascular disease, particularly screening patients who are at risk of ischemic heart disease, any sort of coronary artery disease. I've just had a chat with him myself, and he's told me I'm really high risk. If you see me sit down for a bit, you'll understand why. But anyway, thanks, Bal, and I'll be coming to see you next week. So, and then we've got Dr. Shabir Mishala, who's a nephrologist at Royal Free, and he's an expert in kidney injury, hypertension, chronic kidney disease, transplant, again, in a very big centre at the Royal Free. So I'm delighted Shabir's joined us. And finally, Mark van der Pump, who's a consultant endocrinologist, and he looks after PCOS, thyroid, and diabetes, and also low testosterone, which we're going to bring into our case today. So I was hoping that we could make this all interactive. So don't be shy to interject, ask questions. If you don't understand something, you can ask our panel. It's not going to be a didactic slideshow with lots of information. We want to make it fairly informal and try and learn something together. So what I'm going to do is just put on our case study. Now, this sounds like me, but it isn't. Okay, just to make that clear. All right, especially after that first line. So this is the case study of a male Asian who's 55 years old. So he presents with progressive erectile dysfunction and low libido. Comes to the clinic seeking some treatment. You examine him. Got a high BMI, 35, and a waist circumference of over 100 centimetres. So he's clearly got a bit of excess padding around the midriff. Clearly doesn't play enough cricket, so I don't know why that picture's there. And he's a smoker, very sedentary lifestyle, works in the city office, drinks. And there's a family history of cardiovascular disease. His father had a bypass, his older brother's had a stent, but he's not currently taking any medications. This is just we see this, fairly often, people coming in, get a bit older, getting a little bit worried. But I see it, with regards to erectile dysfunction. So, just starting off just with the erectile dysfunction, just to sort of, break into this whole discussion. So, if he comes to me, the red flags are the fact that he's 55, but he's getting erectile dysfunction. Now, people over the age of 50 will get erectile dysfunction. Probably about half of men over the age of 50 at some point will get an element of erectile dysfunction, but it can be transient. Most of the time they recover. But those who've got progressive erectile dysfunction, it's a little bit more worrying. So that's a red flag for me. And the low libido as well, again, you just kind of wonder, well, is it just the fact that he's getting poor erections, and it's feeding back, he's getting low libido because of that? Or does he genuinely have an underlying issue? The BMI is high, again, a lot of fat. And he's a smoker. So for me, I generally would just treat him by, oral PD5 inhibitors. So I don't know what anyone prescribes or prefers here, but how many of you would just give him some sildenafil? Viagra?
I would investigate first, usually, before starting any treatments.
Yeah.
I wouldn't really choose PD5 inhibitors straight away in case there's heart issues.
Investigating for the heart issues.
Well, for diabetes, for testosterone deficiency, for metabolic syndrome, lipids.
It sounds like he probably has got metabolic syndrome. He's got a lot of fat around his tummy. Got erectile dysfunction. He's probably going to have hypertension. So it's true. You'd examine him, and you could do some fasting lipids. Do his cholesterol. Do his early morning testosterone. What time do you normally?
7 to 11.
Yeah, so early morning. So don't do the testosterone at the end of the day. And also choose a good lab. It's a really difficult assay to do testosterone. So I tend to use TDL, and I think our ones go, sort of by TDL. So so testosterone is quite important as well. But still, you can investigate. But still give him treatment. There's no reason why you need to wait. If he's got no contraindication, just give him a PD5 inhibitor.
Would you give it daily, or would you give it just as required?
Well, it depends. So if someone's having sex, 4 or 5 times a week, the daily one is probably better. But then if he's having sex 4 or 5 times a week, I don't think his BMI will be 35.
Who's having sex 4 or 5 times a week?
That's why I said this is not me.
Isn't there evidence that daily tadalafil 5 milligrams a day is better than just give it as required?
No, so they're both supposed to be just as effective. The idea of 5 milligrams tadalafil is it gradually builds up. You've got a kind of steady state. It's a once a day. It's got a long half-life, 17.5 hours. So the idea is it gives you more spontaneity. You don't have to worry about taking a tablet and then waiting and then having sex. So you don't need to plan. That's the benefit, and it's good for young people, so they don't need to plan. So if there's a bit of a
cardiac failure. Reduces heart attack, strokes, and cardiac failure.
Is that right, Val? Does tadalafil reduce the risk?
There's evidence.
Yeah. Small vessel, any small vessel disease.
Super important.
That's how they were originally developed, wasn't it?
Anti-anginals.
It was originally intended as a treatment for heart disease.
The interesting thing, there's actually a population-based study in Manchester, and what they did, they looked at people dying, and retrospectively looked at were they on PD5 inhibitors or not. I found that those who are on PD5 inhibitors, Viagra, tadalafil, whatever, lived longer. So apparently, it's not a great methodology. That's what this study is. 80,000 patients, actually. 80,000 patients.
Can I just say that actually I'm not sure he's going to live 5 years anyway.
No.
So just say that with a waist of over 100, that's over 40 inches. So you've got to add in 3 because he's Asian. For starters. So, and a BMI of 35 at that level. He's, and with that family history, he will not live till he's 60.
He's looks hot in the picture.
I think that's the team he's a horse.
That was 30 years ago.
That's what you think he is.
I think that's theatrical. So I mean, this is a major. Your point. I get the just treat him, but actually, this is the only chance you've got to save his life. Actually, in your next couple of weeks, when you do with him.
But then again, if he's going to live 5 years,
Might as well be happy.
happy 5 years.
Can I check on some very important things here? One is the age thing. Obviously, maybe not Asian, but what the age thing? Your subject is a young slipper lad of 55. Some of us have just cruised past that. I mean, what are the signs? I mean, obviously nothing wrong. What are the signs? I'm asking my friend Sandeep's here. So, what are the signs that one should be aware of, apart from maybe what we're talking about? What are the signs you can be aware of? What are the things that you could do to sort of nip it in the bud, if that's an expression that suits? I'm not sure it is.
Nip it in the bud, in terms of ending up in that kind of state?
Yeah.
I mean, for me, and this is what I keep telling my patients who are in their sort of 30s, 40s, is I think the biggest problem here is weight and lack of exercise. I mean, those two things, if you don't put on weight and you exercise, I think you probably prevent a lot of this. They're the two key things. If you're putting on weight, there's clearly something wrong. Particularly now, we're looking at the effects of ultra-processed food, and what we're eating in this country is just complete rubbish, isn't it?
Yeah.
Let's be realistic. We look at UPF consumption here versus France, and we're doing what, 60 to 80%. The French eat about 20-23%, and the Italians even less. So, I mean, our diet here isn't great, which is why our obesity rates are going up, and I think a lot of problems that we see are all linked to obesity and a sedentary lifestyle. So, people just start exercising. I think the culture of exercise.
Data, by the way, is that if you have 10 calories more than you need for 30 years, you gain 20 kilograms.
10 calories.
That's a bite. That's a bite of an apple a day more than you need. If you take 10 calories off, you don't lose any. So the problem for a lot of people, actually, and I suspect it's with him, is that his genetic. You've got to catch them at 35, and all you need to do is measure his waist. That's the only thing you need to do to capture the people who are at risk of moving to this sort of metabolic syndrome, and get the intervention in there early. But even then, you're sort of holding a position. You're not reversing them. And a lot of people have got a lot of genetic reasons for the weight gain. That's very much out of their control. So it's not just a simple, they're not, a lot of people dieting that I see are dieting, doing a much exercise, and they're not shifting a pound. So it is difficult.
Those same patients, can I ask you, are they still not shifting a pound if you put them onto Ozempic or?
No, they lose their 10 to 15% on Ozempic, the others. But the point I'm making is that the genetic factor here is such that about 70% of his weight is genetically determined. He's only got 30% he can deal with. And you talk about exercise, but actually exercise in total is only 5% of what you can do. So exercise is quite good at keeping you there on a plateau once you've got there. But in general, in a population study, a diet and lifestyle intervention will at most give you 5% weight reduction, at most. And the problem is that less than 20% stay there within 3 years. Everyone else creeps up, and then they end up at a higher place than they were when they started, and they have that stepwise progression. It's much more difficult than people realise. So blandly just saying diet and exercise, it just doesn't work, as we're finding.
Yeah, it's an important point, isn't it? Because we just tell them that you've got to lose weight. When they come back, say that I can't lose weight, you just think, well, they're just not trying hard enough. That's a really important point. You're going to really get them down. You're not getting them down to, a BMI of 23 or something like that.
So Mark, if you're saying that the problem is that it's genetically determined, are we saying that the mechanism then would be something like insulin resistance happening at a much younger age?
Yeah, I mean,
and if so, would you go for something like metformin in someone like this, even at a younger age?
Well, I mean, what I'm saying is that if you speak to, this is the sort of kid who turns up at his days for his first day at school, and he's shipped off to the school nurse for a chat because he's identified as being overweight. If he's going on a school trip at 8 years old, he's the one who's overweight, and he's got cucumber and carrots in his box, and everyone else is having crisps. Some people kick off at puberty. It's very genetically driven, this, and your ability of your fat cell to withstand any weight loss is very clever. It's got a way. It's like a sponge that just shrinks a bit. It sits there waiting for you to have a weak moment, and it just comes back again. But it's got a way of learning behaviour, so you're not even given the same rules as you go through life. Your goalposts keep shifting, so whatever worked at 25 doesn't work at 45. It's that feeling of just, so people just reach a point in their 40s often where they're doing so much and they're just getting nowhere.
Yeah.
And it's very depressing for them, particularly when society assumes they're just eating too much.
Yeah, no, it's an important point to take home. Yeah.
And even for just one point on exercise, because I see, you know, few men who comes in like, you know, I'm on the bike, but I've still got this belly and I can't shift it. And, you know, there is a difference between endurance exercise, which, you know, you're just building your stamina with minimal exercise, calorie burning. But yes, you could be on the bike on a monotonous exercise for hours. That won't make you lose weight. You know, endurance exercise does not lead to weight loss. It's actually, you know, weight exercises or strenuous exercises that does that. So you see people sat on the bike or, you know, for hours and hours, they've still got the belly. And as we said, it's not the BMI only, it's the waist circumference with the metabolic syndrome.
Yeah, I mean, we're moving away from BMI quite a lot now because, you know, when we assess patients, you know, got really high BMI, but they're like this stocky and this built, you know, and so we're going on waist circumference. I mean, classic case here, before I sort of move on to what we would look at with cardiovascular risk is, you know, someone like him. I mean, we're so kind of, sort of, you know, focused on his erections in what I do. You know, if he fails tablets, we move him on to injections. Ultimately, if he's fit enough, you know, we'll put an implant in. So, you know, I mean, it's one of these. So I don't normally, you know, you just, you know, all I'm focused on, I mean, we're doing a more holistic approach here, but I'm sticking two of these cylinders and that into his tummy and that into his scrotum. Roland's laughing. He does these as well, so I'm not sure why he's laughing. Basically, you pump it up, you know, that'll get fluid in there, it'll go hard, and it gets an erection. That's all I'm focused on. Because we're surgical, we're not as clever as some of these guys here. But I just want to go to Bal because he's a very...
So can I just ask, before you move on, these things are obviously very, very sensitive. And I'm rather hoping this doesn't happen because looking at that... look at that. I'd rather not look at that. But is it the same sort of thing that seems, you know, that is the biggest problem, which is the psychology, is people not wanting to come and see you, not wanting to admit to it, going sort of self sort of medicating. What are the rules about self-medicating on this?
I mean, you're right. I mean, a lot of people don't present. I mean, it's a lot of embarrassment. And I think, unfortunately, with men, it's very different to females who will go and seek help. And you can see, you know, if you look at the publicity around breast cancer versus male cancers, is very different. They're very vocal. They're very proactive. Men just don't present. I mean, I do a lot of penile cancer. And every year, I mean, we do about 150. And I mean, Roland Rees, my colleague, will also testify. Every year, we get people coming with big cauliflowers growing on their penis. Okay, why is that? You know, and ultimately, it's because of embarrassment. And men just do not seek treatment. And you would have thought in a free healthcare service, where you know we see within 2 weeks they will not present for like 2 years until it gets so bad that someone is telling them that you're smelling, disfungating, or something's not wrong with the age of retention. That's when they present. So, and, you know, so embarrassment with erections as well. You know, so all a bit of a, you know, masculine thing, you know, to sort of feel emasculated. They can get over the counter. I mean, a lot of men now are getting over the counter sildenafil. You can get 50 milligrams over the counter without, you know, with the pharmacist just doing a screening. So that's got more case finding. But also, I think, you know, Viagra's been around for so long. It's all become part of the culture. I think people are a little more open to discuss it. Prior to Viagra, I don't think, you know, people really want to talk about sex lives, but we're a little more open now. So you had a question?
Talking about sort of weight loss, a couple of years ago I heard that sort of the microflora of the gut was going to be important, and people who are fat had different bacteria in their gut than people who are skinny. Is that still the thoughts, and is that going to be the answer going forward?
Well, I think the guy at King's hopes so, for the cost of his app. So, I mean, I would just say that at the moment it's a completely unknown area, and I wouldn't be spending money on the Zoe app for the moment until there's more evidence. I mean, Julian might know.
Well, the findings of the initial data collection were very disappointing. And the problem with the microbiome is that it's so fluid. So if you have a vegetarian diet for a while or a meat-based diet for a while, it will completely change within the individual. So the problem is it the microbiome which is in the stool which is important, or the microbiome which is in the bacteria lining the gut? Of course, to get that, you've got to have some sort of catharsis to get to it. So it completely disrupts everything. So the actual research is really stuck at a stage as what is normal, and until you can say what's normal, what's abnormal, and so until you can answer those questions, so everything you're reading has gone beyond the initial phase, which hasn't been answered, which is what is normal and how can you manipulate it to make a difference. But there's also sort of anecdotal things where people say, I took a course of antibiotics and then my appetite completely changed and I've lost 10 or 15 kilos. There's lots of anecdotal evidence that yes, it has a role to play, but it's a long way off being mainstream.
So we're not looking down the microbiome route yet.
I think we're looking at it. So there's a huge amount of it. And so I was interesting. I don't know if anyone reads the Times. The Times today has a chap who was exactly the same after he was a kid, and he used to go into his local KFC in the East End of London. And when he was about 20, he went in there and ordered his sort of bucket of grease and everything else. And they came with him with a card. And the card had been signed by all of the staff in the restaurant because he was their best customer. Wow. And he said, and I was really embarrassed because it wasn't even my favourite. And then he acquired weight. So he went on Ozempic and he's lost 10, 20 kilos. But he started to investigate into, okay, what made me, what changed my appetite? Why did I resort to food as my comfort? What was it about? Because when I lost my appetite, with the Ozempic, I didn't have the same issue. Then I had to address what was it about eating, what did eating do for me, which drove me to the position that I was in. I needed to take this drug, and the drug, and he was saying it was very interesting because it changed his persona, and he felt a bit depressed on it, felt down because food gave you joy, and of course for all of us, food, and I look at the dad's here, but I'm going to make him the dad and kind of to an Asian household and everything. Who do you think's going to eat all this stuff? Well, there's only 4 of us here. You've got enough for 20 people.
Yeah.
And it's so cultural. That's the way to show what a good host you are. To show, as kids, we had that mentality to leave anything on your plate was a sin. There are starving children in the world. Yeah. So we're culturally brought up to overeat. That's normal. And then to switch it off, very hard, very difficult.
Okay, good point.
Sorry, just a question more around the erectile dysfunction, no libido. If, say, the person didn't have like a cardiovascular disease or an OveCAC, what sort of other treatments and therapies and things do you commonly look at sending the patient for before going down the route of the kind of surgical?
Yeah, I mean, it depends on how bad the erectile dysfunction is. I mean, if it's mild, then you may just tell them to do some lifestyle changes, pelvic floor exercises, a bit more aerobic exercise. That's without the medication. I think generally the ones that we see will be moderate to severe, where they will need some therapies. The low libido will come on to, especially in someone like this. But essentially, if your early morning testosterone's borderline or low, you can give them a trial of TRT, provided they're not in the fertile age range. Because remember, long-term TRT will make them azoospermic. So just be mindful of that. So there's a few things you do try which are conservative. You'll see things advertised like horny goat's weed and ginseng and all this stuff. I mean, the evidence is brilliant. There is L-arginine that you can give. There's herbal remedies, but they're not that great. I think it's so easy and accessible to get generic sildenafil, tadalafil, just get them going again. And sometimes you need a short course kickstart. It's got stresses as well. These are work-related or relationship problems. Look into that because there's always going to be that psychogenic element as well. So, if you've got poor erections, it's going to have some, difficulties with the partner. And try and address that. So we try and bring in a psychosexual counsellor as well if there's an impact there. So that's generally what we do, which is more conservative.
Just on the ED drug side, you mentioned sildenafil.
Yeah.
Do you transition to alternative PDE5 inhibitors? And
You can switch
as well.
Yeah, for some reason. I mean, I don't know why, but there is some data showing sometimes if you get a non-responder to one, you switch to the other. And if they don't respond to that, then you go on to injections. Yeah.
I just wanted to ask what screening pharmacists tend to do, because I just wonder if we're missing an opportunity there to make other lifestyle cardiovascular interventions.
Yeah.
And I don't know what they do.
I think they just check that you're not on nitrates.
Right.
And your exercise tolerance is enough, so you can take a PD5. I don't think it's like anything major. So it's just allergies, and are you on medications that might be contraindicated? In which case, they refer back to the GP.
Because you do wonder if that means that then stops this kind of patient presenting and then having all of this other kind of
No, it's true. Yeah. But then those who don't respond to the medication, they're more likely to see someone.
Yeah.
So it's either catching them that way or not catching them at all. At least you catch some of them. Okay. So just moving on so we talked a lot about the other risk factors here, and one of the big ones is you've got this family of cardiovascular disease, and when you look at erectile dysfunction guidelines, there's a lot of data now showing cardiovascular risk. So I want to bring in Bao, who's our sort of resident cardiologist today, to just what is? Do you think this is a load of rubbish that if you've got ED, you're going to get a heart attack in 10 years?
No. Very, very good evidence there's a link. All I can say with this chap is lucky he had ED, otherwise, he would have kept floating along without getting, being flagged up. And even without the ED, anyone saw this patient, they'd say, obviously lifestyle advice, and you should go get checked out, particularly with that family history. We haven't put his lipids up. He's almost certainly going to have unfavorable lipid profile, high triglycerides, all, risk factors. The link with ED, there is definitely a link with cardiovascular disease. We know that. A lot of patients that come to us, tell us as a side, I've had ED, so you know that it exists. So we know there's a link with CVD and ED, but also the risk factors for ED are the same risk factors as you would get for CVD. So there's a big crossover: hypertension, diabetes, being overweight. And there was a theory or the initial theory was that you get ED because you get atheroma of your arteries everywhere, and that affects your erectile function. Actually, it's probably not related to established atheroma, but more to endothelial dysfunction, which then leads to the development of atheroma. So you have an opportunity that if you pick them up early with all these, as we've been talking about, that you can identify that they would be at risk. So I had a patient yesterday, and it's topical, almost like he came. Funny enough, came because he saw David Gower on and come to OneWelbeck. He says, I've come for a health screen because David Gower had a health screen. Literally, not joking, 57-year-old. And in the process of telling me and he had very high cholesterol, low HDL, and then threw in that he had ED. So I said, well, funnily enough, we're doing an event tomorrow about this, and there's definitely.
Same here.
No, when I saw you last year, I didn't mention the ED at all.
That was on that private WhatsApp that we won't discuss.
You said there was nothing to worry about.
So yeah, huge crossover. But as Mark said, this is a red flag patient. If he, the shame is he's waited for a symptom that troubles him to come and see a doctor that someone hasn't said to him before. This is what you need to get done. And certainly the biggest one for me, fellow cardiologist in the room, is the family history. That's always a concern. It's one sort of you can quantify the least well. So I would say get on. I would screen him. I would try and formalise whether he does have established cardiovascular. I'm sure he will. And then get him onto all the right medications, treat all his risk factors, and address all those issues in addition to the lifestyle stuff that we've talked about.
So what kind of screening do you do for someone who's like this? Is it just blood pressure and lipids?
Yeah. So the silent killers. So blood pressure and lipids would be the two that you want to know in terms of their overall cardiovascular risk. So the two silent ones that the NHS are big on people checking. That's what we did our thing last year. Try to raise awareness about it. And then if you want to go further with a patient, they come to a cardiologist, ECG, echo, those tend to be, unless they've had an MI in the past, they will almost certainly usually be normal. The test I find the most useful, and a bit of controversy because it kind of falls into the pure screening, is doing a CT. Who you're not quite sure where they are on their trajectory. Sometimes you can get very high risk patients who have normal CTs, which then you get into the genetics and say, well, actually, congratulations, your genes are protecting you. But I personally find CTs very useful, and radiation doses now are very low, and I think you get a lot of very useful information from it.
So, say for instance, he underwent CT coronary angiogram, and he had a calcium score of 10. Is that significant?
It depends on the age. So for his age, I've got 49 and it's 55, isn't it?
Yeah, 55.
So for his age, 10 is probably bordering on significant.
Is it?
When you do the calcium, as we chatted earlier, when you do the calcium scores, you get where they are for their age, because eventually everyone gets calcium in their arteries. So if you do a calcium score on a 90-year-old, the number you get is quite different to the number. Well, the significance of the number you get is different. It's more significant in a 40-year-old, that number, than it is a 90-year-old. What I'm trying to say, very badly, is so you would take that into account. You could make an argument with family history with his metabolic syndrome that actually, even if he had a normal CT, why wouldn't you want to minimise his risk of having a bad event? And if he had a normal CT, which I don't think he would, at 55, chances are it wouldn't be normal. And and as Mark said, he's probably got 5 years. So I would expect him to have calcium score over the 90th percentile, and probably significant, or the beginnings of significant disease.
So do you think I've done the wrong thing by just giving him the medication without sending him to you first?
I mean, sending him to a cardiologist, definitely, or you could, but making him aware that this, the ED may well be a representation that there's much more. The ED is not going to kill him, is it? And so if we use those terms that if you don't get checked out, there's a chance you couldn't make 60, then that's a good reason to get checked out. But as we know, men like to bury their head in the sand, and if they don't get symptoms like erectile dysfunction, they'll just carry on their own way. So it's sort of forcing them. So I think saying, look, actually you should go and see a cardiologist, you should get your cholesterol checked, you should think about having a CT, I think is very useful.
Well, you don't think just give him the tablets, he gets a bit pumped up, starts having sex, might induce a heart attack, something like that.
That's the possibility. Yeah, exactly. Well, that's the possibility. That's the worry. No, that's the worry.
I've not had it yet.
I think it does depend if it's your regular partner.
Couldn't possibly comment.
Can I just ask, in primary care, we just have a Q risk that we do. What do you think about the Q risk?
So the Q risk is okay. I'm not a big fan of it, and mainly because the Q risk is weighted for age, and if you're young, it's not very good at picking up. And in fact, this 57-year-old, and that's not young for Q risk, he said to me he was told by his GP last week with a cholesterol of 7 and an HDL of 1 with ED, and I think a bit of a family history, that because he was slim and he was fit and healthy, that they wouldn't recommend. So I can only presume someone had typed in a Q risk and got less than 10%, which I think borderline scandalous, because that's someone you wouldn't, What I like to do in younger people, I put this is, I don't know how many of you know about it or use it, it's called a lifetime. So Q risk gives you a 10-year risk of an event. Okay, so heart attack, death, stroke. The lifetime risk will give you your, and you can type the age down at the bottom. When I was playing with this, when I did a talk last week, it defaults to 90. And funnily enough, your risk of having heart disease at 90 is 100%, which I thought was very good. And I'm not sure that they try and scare you into knowing that. So I put it, I think I've got 75 there. But I've got slides, and I won't bore you with them today, but a person with a very unfavorable sort of metabolic profile, you put a Q risk, they come up at ridiculously low, in their mid-40s, like 2 or 3%. And by the guidelines, they'd be sent away. Yet if you put them in, if you just increase their age by 5, that risk goes up a lot more. And then if you put them in a lifetime, and the lifetime risk actually is telling us what's their, and I think that's more important. It's all very well saying you're not going to have an event in 10 years, but what happens at 10 years plus 1 day? So I advocate using the lifetime risk. It's also more useful for sort of convincing patients because a lot of the men, particularly men, will go away with, oh yeah, my Q risk is 4.9%, don't need anything. Lifetime risk, I think, much more important. So not a huge, obviously the Q risk, you know, I think everyone should be on a statin, but that's slightly controversial. But if you have, you know, if your Q risk doesn't come up to what it should, and you know, I think you're missing quite a few people.
Yeah.
Should we be using the newer like cardiac markers, ApoB?
Yeah, all helpful in further risk stratification. So like LPA and ApoB are very useful. LPA is a sort of a one-off, doesn't change with treatment. ApoB changes with treatment, so it's a good way of monitoring ongoing risk. I like using LPPLA2, which is an inflammatory marker, a vascular inflammatory marker. So I use those as well. Those are very useful in people. If you catch them younger, the CTs are normal, but they are. And I don't know if you know about carry scores. The CTs they look at the perivascular inflammation, which is a marker of future cardiovascular risk, even with normal arteries. So I think Julian's story of they said the carry people did a when they brought people in, there was a journalist from Telegraph who was 40, no obvious risk factors. His arteries were clear, but his carry score was ridiculously high. And they said, you know, let's go a bit deeper into your lifestyle. Typical journalist, you know, bad hours of sleep, takeaways every night, just unable to sleep, you know, sort of a lot of risk factors leading towards that. So, and the carry people will say that can give you, which is a bit of a scare because I historically would say if you've got normal coronaries, you know, I don't really need to see you. So there's even that aspect of it now as well. So there are definitely other things that you can do to further risk stratify these patients.
Last question. Sorry, go. Yeah, go. I was going to ask a simple question. A lot of what we talked about this time last year with the screening was about getting there before the event.
Yeah.
What's your ratio, do you think, between proactive and reactive people you see?
I don't know. I don't know if I could give you an answer. There's another slide. I'm not going to put it up, but so one of the studies which kind of led to this whole. So we're very good in this. So if you look at rates of cardiovascular death in the Western world, it's actually dropping overall. If you look at people under 50, it's rising, and that's for a lot of reasons: lifestyle, diet, you know, all those kinds of things. And there's one study which basically took about 2,000 people going into hospital in America. It's all in America, multiple hospitals with either heart attacks or threatened heart attacks. And they looked retrospectively and said who would qualify for treatment had they gone to see their doctor the week before. And it was something stupidly low, like 20%. Yet they came in with a heart attack. Yeah. So I don't know if that answers your question, but I think it sort of leads to we don't do it very well. And I think if you get people early enough, there is very good evidence your ratio would go up. But I'm not sure. I don't think I could give you a qualified answer as to the pro versus re.
So one of the things which always bothered me about, which, you know, as I get beyond 60, is the commonest cause or the commonest presentation of heart disease is sudden death.
Yeah.
So in the group who have got to hospital, presumably you missed the group who've already died.
Oh, totally. Yeah, no, absolutely.
So actually, those figures are much higher.
Oh, absolutely. And one of my taglines to my patient when I'm trying to convince the 45-year-old to go on a statin is, "I don't want your first event to be your last." Because actually, if you could, another controversial view is, if you could guarantee that no one ever get a plaque rupture in their artery, you know, would you really be that bothered? Because it's a plaque rupture that kills you. So when you identify on a CT someone's got a plaque, and sometimes the radiologists will say it's a vulnerable plaque, you know, they go on their fitness drive or, you know, decide on Viagra to go and have, you know, get a mistress and go for it. They could rupture that plaque and that could be it. And that's the most tragic, you know, event.
Probably just follow on all ASIF's patients into yours, and probably if he's dashing out Viagra's, just book them with you next week.
No, absolutely.
Yeah. So it's in one month.
Yeah, no, you're right.
Exactly.
You're right.
Yeah.
And the people who make it to hospital are kind of self-survivors, aren't they? They've sort of survived that event, and that's always good. They have a higher risk in the future, but you do miss and a number of patients have come because guy at work dropped dead at 45, or every London marathon there's two deaths, etc. So those are the ones you want to pick up.
Can I just take a question? Just the chap next, Roland.
Yeah, quick one in terms of the CT angio. If his CT angio was completely normal and he refused to go on a statin, what would be your next steps in terms of a repeat CT angio? What would be the cadence?
I think if it's high enough risk, I would have a very, I'd say, look, even if your angio is normal now, it's not going to be normal in 5 years. You could offer high enough risk another CT, so I'd repeat your CT if you definitely don't want to. I could do those other risk factors, the cardio stratification markers, and say, or persuade them to have a carrier score. Because if I felt they needed one, I'd do as much as I can to get them to take one. But ultimately, I've got people with calcium scores of 9 on the 90th percentile who won't take a statin. So it's very much the individual choice and how we, portray it to them.
And would you repeat it as early as a year? Or?
I don't think a year's too soon. We're going to be careful. I mean, it's not a huge radiation dose, but you don't want to do. I think the evidence at the moment is 5 years. It'd probably be a good interval. So I'd say that.
You mentioned HDL earlier on, and low HDL. We know that HDL is obviously preventative and protective and all the rest of this good stuff. And if I often see low HDL, and increasingly there's advice that starting a statin is going to elevate that level. Is that true?
No.
There's no evidence of that.
No, there's nothing that really, there's nothing proven that raises your HDL. Your HDL is predominantly genetic. You can probably bring it up, 10-15% with lifestyle, diet. Statins, some of the statins, they'll say it raises it by about 10%, but you will never get it to a level where, and often what you see when you treat patients with statins is the total cholesterol goes up, but so does the HDL. So the ratio kind of stays, in the same ballpark.
So you would aggressively treat low HDL then?
You would, but you couldn't use it as a marker for kind of any, that the treatment's working. You just accept that that's going to be the case. You want their total cholesterol, and actually, I personally use HDL more in primary sort of identifying patients, but once they're secondary, we know the guidelines are getting the LDL down as low as possible. So someone who's had a heart attack or a stent or a bypass, you want that LDL, historically 1.8, now 1.2. I would say in someone who's young enough, high risk enough LDL, you can't have a low enough LDL. So I think the HDL is useful in that sort of initial screening thing, but then not really, but personally not very useful after that.
So, Gentleman in brown.
Just want to say, obviously listening to this, it's a multidisciplinary approach, isn't it?
Totally.
It just makes you think, I'm looking at general practice and the corporate medicine I work at. There almost needs to be a system where if you pick something up, then you contact your colleagues from MD assessment, MDT. Whereas psoriasis, it's gout, it's your erectile dysfunction, it's a heart issue, it's an endocrine issue. And I'm just wondering, do you guys work that? Have you thought about perhaps working like that? Because you obviously get hard, don't you? I can solve this, but these are marks for other things. And you need a whole holistic workup. And when you have that, the individual, the patient, is more likely to make change. So when you look at the cycle of, shall I not, etc. And I think that's where the answer may lie with men, especially on this.
Yeah.
Because you all do your little bits, but they overlap with other bits. And sometimes you can make an intervention that harms another intervention in that metabolic syndrome. What's your thoughts?
We designed that already. I think we haven't got it out yet, but we are just in the final
So
stages.
why is he prescribing?
Well, he hasn't read the guidelines yet. So we've got a full men's health pathway over 2 days where people will come and people presenting
This is
with
a private,
days.
obviously.
Yeah.
Okay. But also in the NHS, you look at costs. I mean, and that's where your biggest win always is, isn't it? Those who can't afford. Okay. But if it was something like that there, that's where you'd have the most gain, wouldn't you?
Yeah, I mean, but the problem, as you know, the problem with the NHS is about resources and timetable.
But if you look at the resources separately, it's probably costing you more than having one holistic approach.
Yeah, sure. What would be costing the government? Yeah.
No, you're absolutely right. There's not enough joined up thinking, totally. I mean, the amount of people that come to me who have deranged LFTs and I send them off because everyone will certainly got a fatty liver. Yeah. So, they've got ED. But I, interestingly, will always refer them on, because I usually want to put them on a statin, refer them to gastro for the LFTs, but I'll never send them to urology for their ED. So you're right, there's all these different things.
If you're the other person, you've got a whole team telling you, and we can sort you out.
Yeah. And that's got to be the best way. Yeah, totally.
So there's a question there, and then we'll go to the front.
For patients who are intolerant to statins, I've heard a bit about two different medications. So the ezetimibe with bempedoic acid, I think, and then the injections. What's your opinion on those, and how do you decide which one to choose?
There's the evidence for ezetimibe. My personal view on it, particularly if it's high risk, it's not particularly effective, even in addition to a statin. Bempedoic acid is relatively new. It's sort of come onto the market sort of in the last 18 months, 2 years. Supposedly doesn't give the side effects of statins. So I've started it on a few people. I haven't got back enough information. So I'd certainly try that first. If someone's on a high dose statin and tolerating it and they're still not to target, then I would definitely go for one of the injectables, whether it's a PCSK9 inhibitor or inclisiran. I think Matt wanted to tell me off about getting CTs every 5 years.
Not at all, but my question was just sort of building on this gentleman's question here about screening. Do you think that we are nearing an NHS screening programme to encapsulate not only the cardiac aspect of this, but the full men's health journey?
Yeah, I personally think we're very far away from it in the NHS. I mean, even in cardiac, we do screening really badly in the NHS, and even worse, we do secondary prevention even worse. So if someone's had a heart attack, our methods, or certainly where I work, the mechanisms of looking after them and making sure their HbA1c is under control, making sure their lipids are to target, making sure they're doing their exercise, all that kind of stuff. They do their rehab, which is very useful. So we do it really badly, and again, the point is right. We should be looking at it. We're talking about stopping someone over the age of whatever buying cigarettes. Actually, getting people screened at younger ages, identifying is probably just as effective as a health economic measure.
Just one final question here.
I'm hogging it today. Sorry.
No. And so, are you an advocate? So, I'm a GP. Are you an advocate of the 5% Q risk for starting statins? Are you an advocate for the 5% Q risk, dropping the Q risk?
Oh, totally, totally. Yeah. For the very reason that I don't think 10% picks up enough. So 5% would definitely pick up a higher risk population, and if that doesn't do it, I would do it for lifetime and then do the ApoB. And just if you think someone needs it, you're probably right that they need it. That's And numbers are numbers.
Great, thanks.
I just want to sort of move on because we also picked up on this low libido, and we talked about investigations, early morning testosterone. And if I was to come back to the panel and say, well, he's got a testosterone off between 9 and 10, which if you look at the British Society of Sexual Medicine guidelines is classified as borderline. I wanted to bring in Mark as the endocrinologist. So he's come in with erectile dysfunction. We've kind of referred him on to valve to sort out his cardiovascular, but what would you say in relation to his borderline early morning testosterone?
Well, I mean, in terms of I suppose, as a problem, actually, true hypogonadism is only present in less than 1% of the male population. So it's actually incredibly rare. The problem you have is separating out the true people who have disorders of the pituitary or testes versus those that have a reaction, like what we call a non-thyroidal illness or eugonadism, which means they've got a slightly low total testosterone, but they're not truly hypogonadal. And if you correct what's going on, their testosterone will rise naturally. The difficulty is, and if you look at the data, about 5% of men at about the age of 70 have got low libido, erectile dysfunction, low testosterone. It's about 0.6% between 50 to 59. It's relatively low. You've got to establish whether you're looking at a true abnormality. So you do need your FSH, LH, SHBG, prolactin, and thyroid function to look at the whole pituitary axis. The majority, so if they've got a raised FSH and LH, they've got primary gonadal failure, and you're sort of fairly home and dry in terms of the diagnosis. The difficulty is that with the people with a relatively low FSH and LH, the secondary hypogonadism, which is a classic biochemical picture in the metabolic syndrome. You've got to do the SHBG to establish whether that's a true total testosterone, and you can measure the biologically active testosterone, but those assays are notoriously unreliable. So you're still better off using the total testosterone and eyeballing it alongside the SHBG. And a lot of men, this will have an SHBG of about between 10 to 20, which means actually their free testosterone is comfortably normal and they're not hypogonadal. So there's just the problem we have with any range is that knowing what your cutoff is going to be, and there's going to be people on the edge. The evidence is that if you could get this guy to lose 10% of his weight, his testosterone would go up by 3 in a median, just to say. And actually, if you're going to treat, as you've done already, by the way, his erectile dysfunction, you don't need to add testosterone in, because if you get that bit sorted, you can work on the lifestyle, certainly for at least a year or so, to see if you can get his testosterone up naturally. And then at that point, you've got a decision to make as to whether you supplement with testosterone or not. But you are looking at a lifelong diagnosis. You're looking at creating the problem you're trying to treat. So when you're getting over 50, if you go for a prolonged course of testosterone, you give them secondary hypogonadism as a result. So when you stop it, their testosterone doesn't come back anyway. So it is that sort of sense of what, and then little things you can help you. I think one of the key things is a hemoglobin, because if you've got good going hypogonadism, you tend to be anemic. So if your starting point of hemoglobin is 16 to 18, you've got a high hematocrit, you probably are looking at sleep apnea, which was not mentioned as a common accompaniment. So if you're going to give testosterone and build up the hemoglobin and hematocrit, that's also a problem. You can also look at bone density, but actually until your testosterone is less than 6 or 8, you don't have as much impact on your bone density, but that can be something that supports your decision in those sort of very borderline grey cases.
But I mean, what I'll say, I mean, he's in his mid-50s. You're going to get a physiological decline anyway, but some people say it's a bit of a chicken and the egg. Could his low testosterone have contributed to his central obesity? Or do you think it's central obesity causing the low testosterone?
I think if you went to an endocrine, they'd have a weekend discussing this with two sides.
I'd love to go to that conference.
I just missed that session. The point is, you've got advocates either way. I suspect that it probably is a secondary hypogonadism associated with the metabolic syndrome. There are advocates that if you give people testosterone in that situation, there are potential metabolic benefits. So you don't have to decide, really. There is a school of thought, and some people do treat and believe it's beneficial. But you do have those other issues. And if you've got a hematocrit of 50, you're into then polycythemia and regular venous sections. You can actually, testosterone can give you obstructive sleep apnea as a side effect as well. So it's not as if you're giving somebody something that's completely risk-free. Plus, you've then got to decide how you're going to do it with the gels or the pack or the injections. It's not just taking a tablet a day as well. So I think it has its problems.
I must admit, the men that are low with a low libido, I do put them on testosterone, particularly if they're PD5 failures. And they think it's great. Why is it that they come back saying, actually, I feel quite good on this?
You're obviously completely convincing that it works, aren't you? So, the evidence of moving you from 10 to 15 is going to magically not as great as people think is the issue. You are doing an intervention that they clearly believe is going to work. And you've been completely convincing it will be. You are pushing an open door on that. Plus, you've got no really objective markers other than them coming back saying they feel better. But in that situation, in your trial of therapy, and they're willing to continue and they're aware of the risks, then that's fine. That's the point I'm making. You're allowed, I think, in those grey cases to offer the trial. As you say, if they come back saying it's the best thing I've ever had, then leave them happily on it. But they've got to buy into the fact that it's a final diagnosis and it is for life. It's not just a short-term trial to reset their axis.
But there's also, like the BLAST study, which looks at diabetic control in individuals like this. Do you agree with that? Do you think if they're hypogonadal and you give them solid diabetic control?
So this is the other half of the debate that there are advocates that giving testosterone supplement to the patients with type 2 diabetes can show improving glycemic control. But you're then looking at, is it well-being? Are they doing more exercise? Is it a secondary effect rather than the true effect of the testosterone itself?
Yeah, next question here.
Yeah. How important is the sex hormone binding globulin for libido? And is there anything you can do if it's high? What can you do to bring it down?
Well, it's not so much, it's important. It gives you, the importance is for you to allow you to calculate in your head, really, the free testosterone. It's not in itself, it's a marker. So basically, if you've got insulin resistance, you don't make SHBG. If you're a thin 10K runner, you've got an SHBG of 100. If you're a fat, snoring, obstructive sleep apnea, you've got an SHBG of 5. All it's telling you, I've got a patient with a testosterone of 5, but if their SHBG is 1, they're not hypogonadal. It's not so true at the other end of the spectrum, by the way. It's not so helpful, but at the lower end, it can just help support the fact that actually testosterone replacement is not the answer here. It's actually weight loss. And if you can actually say to someone, and obviously we've now got drugs that can do it, if you can get the 10 to 50% weight reduction and see that rise in testosterone, the idea of that initial trial of lifestyle is you try and get them to engage in that process first.
Change the binding globulin
Well,
as well or not?
well, I always sort of think all you do is change the number on the computer and you make people feel happier. It's a bit like giving a newly diagnosed diabetic metformin. Their HbA1c will come down, but they won't live any longer. All you've done is made your quaff happier. Actually, you getting the number down yourself is what makes you live longer. So I'm against just magically normalizing numbers on a profile just for the benefit of the computer.
Okay. Yeah, question here.
And if you start TRT, is it like permanent for life, or does it happen a year or two, see how things go, you lose weight, and then?
Well, what I'm saying is that the point I'm making is that if you're making that diagnosis, it's not a reversible diagnosis. If you had a reversible cause, then your year of lifestyle to achieve it. But the point is that if you start it, even if you haven't got it, you get it.
Okay.
And that risk is greater the older you are. So each decade, the longer you're on testosterone replacement therapy, the greater you have of inducing the condition you're trying to treat.
Do you not get a return to function after if you stop testosterone?
Well, that comes on duration of therapy, you see, and how much. I mean, if you switch off their FSH and LH for long enough, then you lose the growth surge to the testing. So if you do that for long enough, you've got a susceptible patient. When you stop, you don't automatically get restoration of the axis.
Would you use HCG and clog and things to
Well, again,
broke the cycle?
yeah, I mean, you can. I mean, again, that then is upping the whole complexity of what is we're talking about is a wide primary care problem. So yeah, if you want to go give everyone 3 times a week HCG, that's fine, but it does make as a practical healthcare issue, that does up your monitoring cost and how that's managed but yes, you can use HCG if you've got a hypothalamic pituitary axis defect.
I mean, what you're talking about, I mean, we sometimes see bodybuilders and anabolic steroid abusers coming in, been taken for years and years, and they don't recover. So obviously there you want to sort of stimulate, particularly if they're still trying to have a family and they're found to be asospermic. So
yeah, Clomid works as well, by the way. So that's the other thing.
Yeah. I think there's a question at the back. Was there a question at the back? Someone had their hand up? No?
Okay.
Oh yeah, I had a question up front.
Yeah. Make a point just around. I think one of the challenges is that patients now are bombarded with low testosterone, whether it's through social media. There's companies popping up, and it's very easy for you to get testosterone checked. And some of the sort of messages that you sent out is around education. But how do you manage those patients that are coming in asking or wanting over-the-counter supplements or really pushing for those sorts of treatments? Maybe not testosterone replacement therapy as such, pure treatments, but those sort of more holistic type over-the-counter type.
Yeah, I mean, they don't tend to listen to me, I suppose. And so I never see them again. Because I just give them what I think is an honest answer. That's clearly not what they want to hear. They will go and find someone who's prepared. All of our phones on the way home will have on our Twitter feed something about testosterone, by the way. Yeah. So the point is, as you say, we're being fed that stuff whether we want it or not. So I mean, I think if people don't face up to what they need to face up to, otherwise you're just pandering to the madness, aren't you? And justifying everything. If they come in with a health agenda, you can only tell them what actually the truth of the health situation is. You can't just say, right, if that's what you want, I do. You've got to have some medical ethics and standard.
Integrity.
So I think we've kind of sorted this guy's erections libido out. He's partly on medication. He's been screened. He's got he's got a bit of cardiovascular risk, but Bal sorted his lipids out. But we're going to move forward a couple of years because there is some evidence that erectile dysfunction is associated with a higher risk of lower urine tract symptoms as well. Sometimes this is one of the indications for low dose tadalafil. They've got LUTs and ED, just given the one tablet. So I'm going to move on a couple of years later. He's still alive. Still got 3 years left before he dies. But he's come along with a new problem. He's getting more problems with his urination. And he's saying that he's bedwetting now. Okay, so he wets bed at night. The day passing urine, typical, a problem that men will get as they get a bit older. But bedwetting is a bit more of a sort of a red flag. Comes to you dipstick his urine, he's got a bit of blood in the urine as well. So not only is bedwetting, he's got a little bit of blood in the urine as well. So I want to bring in Anthony just from a sort of urological perspective, in terms of, just tell me what kind of investigations would you immediately do on someone like this that comes in with nocturnal enuresis and as well as, a bit of blood in the urine?
So I think the age-old thing I got taught was the bladder is an unreliable witness. And the one thing about the bladder is that there are lots of symptoms from the bladder that could cause one thing, and then lots of different things have the same symptoms. So it's sometimes difficult to tease out. Importantly, he's had a urine dip. It's important to rule out that he's not just got a UTI. And also in terms of if he's a man who's got a UTI, you also have to think, why is he getting a UTI? In terms of his LUTs, he's 55. We're starting to think of at that age group, is he starting to get an enlarged prostate? Is it something else? Is it an overactive bladder? Probably, we'd normally go the main cause, the most common cause for men to have problems with their waterworks is an enlarged prostate. It's not the only reason, but it's the main thing. So what I want to get from him, especially with the nocturnal enuresis. The nocturnal enuresis is, to me and to the other urologists on the panel and the audience, to me that suggests that actually he's got something called chronic retention, okay, until proven otherwise. A man of this age shouldn't suddenly start wetting the bed for no reason at all. And you have to rule out whether or not he's holding back urine, and a post-void bladder scan is important. The flow rate in a post-void bladder scan. If you don't have access to that in primary care, then he needs to come see a urologist, or you can easily get an ultrasound scan and ask for a post-void residual on the request. Now, I like to do this thing where I used to love telling registrars and SHOs about acute and chronic retention. So do you understand what I mean by chronic retention? Is that, yeah, no, some, yes, some. Okay, simply put, retention of urine is the inability to pass urine. Acute retention is usually painful, okay? Suddenly a man or woman can't pee. It's painful, bladder's filling, it's stretching, they get pain. Usually, if they get catheterized, you will have about 500 mils, 550, 600 mils drain out. Chronic retention happens over longer term. So chronic retention is something that happens slowly. And the way I like to put it, if you think about taps, old style taps, not one tap that goes left and right with one lever, where there's an old sink where there's two taps and then a drain, okay? The kidneys are the taps, they're just dripping urine all the time, okay? And then if you've got a blocked plug hole, you can switch the taps on, it doesn't drain as well. What's happening with some of these older men is they pee, and in fact some younger men as well, they pee and they stop peeing, it slows down, the flow's not quite as good as it used to be. It slows down and then they stop peeing and they think they've finished. But actually, they may have had, 800 milliliters in their bladder, and then they pee out about 400 mils over, 3, 4, 5 minutes, and then they leave in, 200, 300 mils, and they don't realize. If you ask in the history, they'll have frequency, they'll have a slow flow. They might have what we call terminal dribbling, which is, where it slows down towards the end. Sometimes they still need to pee. Now, the risk with retention, with chronic retention, is there's two types. There's what we call high pressure retention, and that's what we worry about. And then there's low pressure retention, which is less worrying, but they're still holding that urine. High pressure retention is a risk to the kidneys. So what that means is that with holding back, with chronic retention, the bladder can neither be in a high pressure state, and the function of the bladder is actually to fill and stay at a low pressure. And it's designed very well to do that. Not many things are designed to fill, get bigger, and stay at low pressure. And then it will just, if it gets high pressures, that's a risk of urine backing up to the kidneys. And that's essentially what we call high pressure retention. So with him, he needs some form of post-void bladder scan, whether that's a flow rate or an ultrasound scan. Importantly, he should have a bladder diary. And a bladder diary is really, really annoying for patients. And I tell them that it's going to be really annoying, but they need to do it. Essentially, give them a 3-day bladder diary. We used to say to them, it has to be 1 week, at least 1 weekday, 1 weekend. No one ever does it. Okay, no one ever does it. I give out bladder diaries every week. I think I get about 10% of them back. There's some technology you can use. There's a company in Belgium that makes something called a home flow, and the patient gets an app, and then they get a little urine pot, which is probably about that long and that wide, and they get a bag with it. It detects their flow, so they pee into it. Okay, take it with them, pee into it, rinse it under the tap, put it back in this waterproof bag. It sends their urine flow, the one they carry with them, or to the app, sends it to the clinician. So there's a bit of a better pickup rate with that. So they need a bladder diary, because one thing we want to know as well is, is he wetting the bed because he's producing too much urine at night? Is it because he's in retention? You have to think about other things as well. If he's got what we'll call nocturnal polyuria, producing too much urine at night, then I'll probably be thinking about whether or not I refer to, and get in our cardiologists, our endocrinologists, our nephrologists. Is he in renal failure, especially with the blood in the urine as well? So those are the kinds of things that we need to sort of think about.
What about just on the microscopic hematuria?
Yeah.
Because we see that quite often. You do a dipstick in the surgery, there's a bit of blood there. How worrying is that? What's the pickup rate with microscopic hematuria that you're going to get after the sinister? That's what we know. Do you investigate these guys, or just say, look, I wouldn't worry about it too much?
So it's a good question. I think, so previously we used to investigate all sort of persistent non-visible hematuria. I think it was in over 40s. And then the NICE guidelines on sort of urgent cancer referral changed, and for persistent non-visible hematuria, you now have to be over 60 and have a raised white cell count to be investigated. I would say that it's a good idea to investigate, especially in this age group, even if it doesn't necessarily fit the NICE guidelines. For, remember that those guidelines are for cancer, but hematuria, especially in this gentleman who's got lots of comorbidities, his kidneys are at risk. So I would still investigate him. Ultrasound scan. You can discuss. I mean, from my point of view, I would discuss a cystoscopy with him. Okay, it doesn't necessarily need to be an urgent cystoscopy. And if those are normal, then I would refer on to a nephrologist. Sometimes I try and be a pseudo nephrologist and request the urine albumin creatinine ratio or protein creatinine ratio myself, and then send the results off because I don't know what it means. But yeah, I think bringing in that, it would be sort of, I think it is worthwhile investigating.
So I mean, the risk of, say, cancer in microscopic hematuria, so non-visible hematuria, is what?
So risk of 5 to 10% of finding a significant finding.
Yeah, that includes benign, doesn't it?
It
Stones and things like that.
Yeah. So finding a significant finding, 5 to 10% risk in non-visible hematuria. And as Asif said, that includes, I always teach the SHOs and registrars, trauma, infection, stones, tumor are the main causes of hematuria. So it includes all of those things.
You must get athletes, don't you?
Like you do. Yeah,
you know, so athletes running, yeah.
I don't worry about running.
Long distance runners, diptych them, they'll get some
post-London marathon.
Yeah, there's a lot. In fact, they get frank hematuria as well. I had a patient that did London Marathon, came in and started peeing blood. Yeah.
This is no longer asking for a friend. The issue of flow.
Yes.
Let's face it, once you got into the 60s, it changes anyway.
Yeah.
And it seems to change, or can change, sort of daily or weekly.
Yeah.
One moment you think everything's fine.
Yeah.
You think, yes, proud of that. One moment you think, well, hang on, why is nothing, or why is relatively little coming out?
It can be variable, and it's difficult to know the exact reason. My theory is that the bladder responds in different people in different ways to not emptying properly or having or pushing against an enlarged prostate, which is essentially it's a partially fixed, partially what we call dynamic obstruction, and lots of things will come into play. If you think about the bladder squeezes and then it's got a pipe, it's got to squeeze again. There's a little bit of smooth muscle there, and if that's a little bit more contracted, then it has to squeeze out a bit more. Your flow is going to be a bit slower. If your bladder's got a certain amount of urine in it, it stretches the cells in the muscle well enough that it gives a good contraction. There's something called Starling's law, which Val will know about for the heart, and there's a certain amount of stretch that a muscle needs in order to give a good squeeze. If you overstretch, if your bladder's too full, you'll have a weaker flow. So all of those things sort of play a role in whether or not you get a good flow sometimes and a bad flow sometimes. A good question I ask men, especially a lot of men, like I say, don't say that they've got a problem. How your water works, fine. Okay. Is it as good as it was when you were 20 years old? No, doc. That's really quite a useful screening question.
Yeah. I think the fundamental point with lower tract symptoms is all men will have a problem with their prostate. It's just a matter of when. And what we need to get away from, that this is not a problem. This is not an illness. This is not a condition. You've got an enlarged prostate that will give you a sort of spectrum of symptoms, depending on, like Anthony said, how good your bladder is, how good your pelvic floor muscles are, how often does it give you, symptoms. And it's a purely quality of life until it becomes a higher pressure chronic retention when the kidneys are affected. So if their kidneys are safe, if the renal function is normal, and they don't have high residue, then it's not a health condition. It's not going to affect their life expectancy or any other organs. It's purely quality of life. If you're playing around in golf and if you pee between holes, that's not great. But that's not I always tell men, don't be, I ask the question in a different way. I don't say, if you've got a problem, then how much is this affecting your life? Do you want to spend the next 10 years of your life like this? Or do you actually want to just enjoy your life by having a simple intervention that, most of it is day case and, with rapid return to normal activities? Why are you suffering from a condition that you have, which is impacting on your quality of life?
And what would that intervention be?
Well, how long you've got? So
it used to be very straightforward.
Due any moment.
Yeah. So we've now got, we divide. It's like Anthony said. It's usually the prostate, either the shape or the size of it. So it's no longer just enlarged prostate causes these symptoms. There's so many men with small prostate actually will have more symptoms. So what we have now is a combination of what we call minimally invasive therapies, which are designed for sexual preservation, rapid return to normal activities, but the downside to this is it's not durable. So in people's life expectancy, they might have to have second or third intervention. On the flip side is what we've got cavitating interventions, where we remove part of the tissue. And more nowadays, we are designing these new technologies that doesn't even affect sexual function. It's all about that. It's all about the regret. Some people come 5 years later and say, you know what, I wouldn't mind waking up twice, but now I can't have an erection or can't ejaculate. This is affecting my life more. So that's what we're trying to drive with research. And now with aquablation, for example, this will give you, it's cold energy, so it's water jets that we use, and that just removes that internal part of the prostate and change the shape or the volume of it with sexual preservation.
And would or does a kidney function test pick up or help in this diagnosis? I think it's sort of normal bloods.
In terms of
bloods.
what your
Yeah,
bladder.
Yeah.
So a kidney function test, not directly. However, if you've got chronic retention and your kidney function test is, I would say, not what we would expect. If you've got impaired kidney function, then I would be worried that you've got high pressure retention. From my point of view, usually if there's an ultrasound scan or post-void bladder scan that shows empty, you don't necessarily need a kidney function test. However, in the context of this, with non-visible blood in the urine, probably should have a kidney function test as well.
The abnormal kidney function test changes the dynamic of the discussion from a choice of what the person wants to have done to what you have to have done, because it's a health issue.
It changes it from, this is, lifestyle, does it bother you, does it not, to actually this is going to potentially save your life.
Just a question up front.
Yeah, no, let me make a comment. You touched on some days, and you see this a lot with patients, some days my flow is fine, and other days it's poor. And why does that happen? And I think it's so variable to the external kind of factors that come into play. What type of food you're drinking, what time of day you've drank, how well rested you are, what's the weather like, what you've been doing that day, you've been in the car a lot, so many external factors. And I think when we do the flow rate, it's so important that the patient is educated on how to do an appropriate flow, because if they come in and they've not drank like they would normally drink, and they've guzzled a litre and a half an hour before the flow, ready to go, their bladder is so full, they'll suddenly voice 600 mils and be like, yeah, my flow was great. And then you ask them, is that how it normally is? Like, no, this was just really good. And then you'll find an hour later or half an hour they'll be running to loo again because they haven't fully emptied. So there's all those slight nuances, and you see it so often. So you both hit a real nail on the head there with that.
Okay, there's a question at the end.
Just from a primary care point of view, and taking you back to the beginning of assessing this patient, how valuable do you think a rectal examination would be for this patient?
Or
how much value do you urologists put on it?
Who's going to do it?
So it's a good question. I think, from the point of view, I think it's a good screening tool in primary care to get an idea. We know that the rectal examination is not the best in assessing the size of the prostate. However, it's a good screening tool. I think we as urologists probably do rectal examinations less and less now, particularly for prostate cancer because of the advent of MRI. But I think it's still for benign lower urinary tract symptoms, I think it's still relatively valuable.
Just moving on to, so there's this black box for microscopic hematuria, because we'll do the investigations, you don't find anything, but then you keep dipsticking and there's 10, 12 red blood cells there. So I want to just bring in our resident nephrologist, who's basically the expert in this, because we just end up going, right, here you go, it's your problem now. So what do you do when you see the urologist saying, well, I've investigated him to the hilt, can't find any cause. This guy has still got microscopic hematuria. I mean, we're part of the high pressure chronic retention because we just talked, because that would need surgery. But just with the microscopic hematuria, what would you do in your practice?
Yeah, I guess the first thing to decide is, it depends where the referrals come from, but you want to make sure that depending on the age, all the urological obvious aspects have been dealt with, and some of that will be related to the history of what's been going on. But one of the main things when you see an abnormal urine dipstick and it's got blood in it is two questions: is what else is there? So you want to know whether there's any protein there, and how long has it been going on for? So you want previous dipsticks. You'll obviously want to confirm it with another one if it's an acute thing, but you want to know what's been happening, weeks, months, years in the past, if there are any on record, to know whether it's a long-term thing. The longer it's been going on for, the more likely it is to be a nephrology problem. So what nephrology problems? Well, I mean, it might be something that's inflammatory. Sometimes that could be a real disaster. It could be like a acute glomerulonephritis, but it doesn't have to be anything as dramatic as that. It can have chronic conditions, basically, there's a limited number of ways that kidneys can express their displeasure. And one of the ways is by leaking out either blood or protein or both, and that's pretty much it, or by reducing its function and the creatinine going up. So that's really, as a nephrologist, all you've got to play with, really, because all the other stuff is being handled by other people. And so the common conditions would be, if it was chronic, would be IgA nephropathy. There are other conditions that are structural lesions that we're actually only really kind of getting to grips with now. So things that what is still called thin basement membrane disease. So these are all kind of microstructural abnormalities, which were thought to be completely benign in the past. But actually 20% of them can end up with chronic kidney disease, and a large number of those who progress could end up with dialysis. So some of them are progressive conditions. And some of those are genetic, and we can now pick those up by doing further genetic tests to try and work out what their risk of progression is. But a lot of the problem with the dipstick is it's a very, very rough screen tone, but it's one that we love as well, because we the more dipsticks the better, because you can get more information out of it. It's in a single dipstick in a point of time, unless it's an emergency situation, doesn't really tell you that much. Microscoping the urine, which we used to do, also, in fact, doesn't really tell you that much, because you're looking for that whole chronic progression. So,
do you just like monitor them? I mean, is that all? You don't biopsy?
No, we do other work as well.
The only letter I get back, they've got basement membrane disease, they've got IgA nephropathy, but you know.
Well, to diagnose it properly, a lot of the times you'll see something like, oh, this person's got IgA nephropathy. Well, you don't know that, because the only way you can, it's a histological diagnosis, you would have to biopsy the patient. So a lot of the time it's that decision being made over a period of time and with the patient. Do we go for that? Do we need to do this? Because if you're right, if all you're going to do is monitor, then don't do an invasive test. But sometimes you may need to. So if the function's really going off, or we've got proteinuria that's in excess of half a gram or a gram a day, or something else that makes you think that there's something that you can intervene on. And now actually, even in something as so-called benign as IgA nephropathy, which is not really that benign at all, the paper that we just published via RADAR, which is the National Registry of Rare Kidney Diseases, just showed that IgA nephropathy, a really large group of patients within nephrology, but the chance of ending up on dialysis is much higher than before. It's still low overall, but it's much higher than we thought. And the reason for that is because, unlike a lot of the other conditions we've been talking about, they're going to kill the patient before they get there. Whereas some of these renal limited conditions, they're just limited to the kidney. So the rest of the patient's going to be in relatively good nick, unless it's this guy over here. And so the patients actually survive, but their kidneys don't. And they're the patients who can disproportionately end up on dialysis. But they're also the ones who probably do the best with transplants eventually, but you don't want to get them that far.
Do you think any sort of link? Because I mean, obviously, Bal talked about endothelial dysfunction. So you've got small vessel disease as well, with endothelium. Do you think that's got any link with someone like this and them developing any renal disease later on in life, such as IgA nephropathy or any other condition? Do you think?
Yeah, I mean,
is there any?
It's exactly the same as Bal was explaining. The mechanisms are the same. The kidneys are just part of your small vessels in your body. So back of the eye, kidneys, all of these things. So for example, in a diabetic, those two would go together. And in this particular case, you'd expect that the disease that's affecting those medium and small vessels will also be affecting those in the kidneys. And sure enough, we get many cases, and a good 30-40% probably of what's known as CKD that you would see. If you biopsied those patients, you just see this thing that just looks like it's called chronic damage. It's just basically interstitial fibrosis and tubular atrophy. Those two things equal this thing called chronic damage. And it just means that, well, they've got a risk of, they've already started from a lower level, and they've got a risk of progressing as time goes on. Luckily, most patients with CKD stage 3 stay in CKD stage 3. They don't all progress. Otherwise, we'd have the entire population on dialysis. But there are a number that do, and so that's the reason why we don't biopsy everybody, because a lot of them don't need it. But we know that the same mechanisms that are causing problems with this patient are causing problems with the kidneys as well.
Interesting. That sort of ties in.
Is there a role? So I don't want to start an argument between a cardiologist and a nephrologist, because I know there's tensions about some things, but
normally financial.
ACE inhibitors. At what point would you?
No, I think you'll find that we're going to agree very strongly on this
might
one.
Be the only thing you guys agree on.
Yeah, Pal's crossed his arms very
yeah, straight away, ready for the fight.
ACE inhibitors in a patient like this, is that something you would give? Would you suggest that for him, not from the renal point of view?
So I'll tell you briefly from the renal point of view, and then I'll talk about from the general prevention point of view and the heart point of view. But ACE inhibitors, again, like all these things, you want to make a diagnosis first, or a putative diagnosis. So if they've got protein, you'd use it as a blood pressure tablet on its own anyway. If they've got proteinuria, it's still the number one antiproteinuric that you're going to use. There's plenty of others now available, but that's the one that you'll go for most of the time. And there's certain other renal conditions where an ACE inhibitor is preferred above any other drug. But other than that, it's pretty straightforward from a renal point of view. You can pretty much, if it's a blood pressure problem, you could theoretically use any drug, but we tend to use ACE inhibitors. And then it's the number one antiproteinuric still.
Not much to add. I think there's reasonable evidence. ACE inhibitors are cardioprotective. They're first line in most guidelines for blood pressure management. So, a bit like a statin, if you're going to, if you find a reason to be on an ACE inhibitor, I think there's an overall benefit.
Is it the same if you have one of those ARBs or an ACE inhibitor, or is ACE inhibitor better?
I'm not aware that one's better than the other. I don't know if you
Same.
Yeah.
Same. So you could
My
be
God,
on an
my God,
ARB
this is like a landmark.
No.
Yeah, no, it's more about side effects. So historically, it's more like give you a cough, so change to an ARB.
But it's still got the same kind of benefit.
Yeah, absolutely. So certainly cardioprotective, yes. I maybe an argument that maybe it's ARB is a bit more cardioprotective, but I'm not sure. That's
for Black Caribbean, you choose ARB preferable. Is that correct for Black Caribbean man, or in general? ARBs are more.
Well, so interestingly for the guidelines, so ACEs and ARBs are less effective in the Black Caribbean. So they tend, in some guidelines, they're not first line.
Yeah.
So you could use a calcium channel blocker or a beta blocker first line. They all, in my experience, tend to end up being on an ARB anyway.
Yeah.
But if you're saying was an ARB preferable over an ACE for them, yes, I would say yes. Yeah.
Okay.
I tend to go straight to ARB because I don't need them to come back in 6 weeks and say I've got a cough.
So we're going to move on. This is the curveball for Ahmed, who's our expert in prostate cancer here. So the same guy, he's been on testosterone. One of the side effects of testosterone is obviously, it can cause prostate enlargement. It can just cause a bit of BPH, and probably why he's ended up with these low urinary tract symptoms. But essentially, there's also all this debate about prostate cancer as well. So if he's getting a benefit with testosterone replacement therapy, but he's 55, where does the prostate cancer risk come in here? Is it going to induce prostate cancer, or do we just need to exclude prostate cancer? I mean, where do we stand? Because again, a lot of men are being rejected for testosterone because they say no, it causes prostate cancer or it causes cardiovascular disease. Where do we stand with that?
Yeah, thanks for that. So I think this is one area where there is no real proper guidance on what you should do. I mean, I think for the cardiovascular relationship of testosterone, we've got enough evidence that now it's safe. So that's at least one good thing. I think if you look at all the guidelines, the American guidelines, the European guidelines, and even the sexual medicine guidelines, it says you have to just get out of jail. Their last statement said, well, it's the responsibility of the clinician to assess patients on individual basis. So it's just a cliche to not get involved. But there is enough, and the story, just for everybody, why is risk of prostate cancer with testosterone comes from the reverse. So basically, we treat certain men with prostate cancer by castration. So we lower the testosterone level. So obviously, if you use that analogy, clearly too much testosterone is bad for prostate cancer. But this is different from a man who does not have prostate cancer. So all the studies that has been done on men on TRT showed no evidence that this has induced cancer in men who do not have risk factors, who's been screened. So I think the answer is, I would hope that, especially men at risk will have a baseline screening. So, family history, Afro-Caribbean, obese men should have baseline PSA before starting their testosterone. If the PSA is high, I would say they should have an MRI before putting them on TRT. And then if they are clear, then part of the follow-up for the men being on TRT is to have these, so their hemoglobin, their estradiol, the testosterone level, their prolactin, and the PSA. So that's the 5 things that I do for all men on TRT. Now, to go even further, I now get some more men saying, fine, you've told me I haven't got prostate cancer now, and you told me that I might not get prostate cancer in future. But if I go on TRT and my PSA start going up, would that lead me then to have lots of MRIs and lots of biopsies unnecessarily? And that is a difficult question that no one can answer, because we know that testosterone could drive, benign prostate cells growth and affect their prostate volumes, and that will drive their PSA. So there is a potential that men on testosterone replacement will, if their PSA is being driven up, they will end up being over-investigated for prostate cancer. But I think there is yet no evidence to say that testosterone replacement will directly induce mutation in the cells to cancer cells. And the way I think about it is we're using TRT to bring men's testosterone level to normal level. We're not driving them way above the normal level. So their risk would be equivalent to the normal population.
Okay, good. Any questions on that? Yeah, certainly.
Sorry, how often would you be screening for those blood tests? Is it every 3 months, 6 months?
6 months. So it can be done, according to discretion, but the ones I look after, I do them 6 months with the five test. And you want to check their hemoglobin because you send up for venesection, or their PSA and prolactin, estradiol, and make sure that they don't start converting to fat cells.
And do you keep the threshold for PSA at 3, or is it? Or
Yeah,
is
yeah.
there a certain
No.
percentage above what the previous
Depends on
result
the
was?
age, doesn't it?
Yeah, I mean, yeah. So the PSA, what is normal PSA, is very, very difficult. And we used to always say, like as I've said, it's age, age threshold. But we know that even men in a certain age category will have different prostate volumes, and we know that PSA is a protein that all prostate cells excrete. So the bigger your prostate is, the more likelihood you're going to have a higher PSA. So my approach to it, I take the NICE guidelines. The cutoff is 3 for all ages, and if it's above 3, then they should have a baseline MRI. Then you could use PSA density, which is proven now to be the most accurate, or free to total PSA, as a differentiation for the follow-up. Once you know they had a normal baseline MRI with a 90 cc prostate with a PSA of 3 or 4, then you are on the safe side.
Yep. So one more last question.
So slightly off topic in terms of finasteride, propulsive for hair loss. A lot of men come to see us for that. Any concerns about its long-term effects at all on the prostate function or in general?
Yeah, so on the hair loss is much smaller dose than what we give for BPH. So it's 1 milligram, or we give 5. For the 5 milligram, there is evidence that if men are on that for more than 6 months, it could lead to irreversible erectile dysfunction. And in America, I think it's come off.
There's a big lawsuit with Merck about sexual
massive
dysfunction.
problem. So I personally don't prescribe it for men who do not have erectile dysfunction or other problems, and you give it for BPH. But if an 80-year-old with cardiovascular issues, with severe lung tract symptoms that I really don't want to operate on, I will just put them on it. And you'd be surprised how many men will say, this gave me enough symptomatic relief that thank you very much, I don't need an operation. And the other ones you really don't want to operate on.
Okay. Right, I think we're going to just round it up there, because I think we've covered everything related to men's health apart from itchy bollocks. And, we should have got dermatologists in for that. But I think, if you look at it, just talking about sexual dysfunction, prostate, bladders, the kidneys, cardiovascular and hormonal. So I'd like to thank the panel, so Anthony Noah, Ahmed Ali. I'd like to thank Mark at the end there, Shabir, and also Baz, of course, and also our special guest, of course, David Gower, OBE, and just as a thank you from OneWelbeck for coming along and
This is prescription, is it?
It is. Testosterone.
He's confused with stuff.
Yeah.
Stuff.
So we're going to round up here. However, there's an after-event function, party, whatever you want to call it, on the 6th floor at OneWelbeck for those of you who want to just carry on mingling and networking and having a few more drinks. So 6th floor, is that right, Roops? Once again, I'd like to thank Roops and the OneWelbeck team for organising it. It's been a great session. I've learned a lot. And I'll be booking in with these guys, Bal and Co, next week myself. But if there's anything, obviously, you want, feel free to contact us. You know where we are. And obviously, there's a fully comprehensive service at OneWelbeck that we're offering. So feel free to start connecting with us. But again, thank you very much for coming along. Very interactive, and I hope you all learned something. And I wish you all a good evening.
Thank you very much.